Simran, shall we start? Okay. So good morning, everyone. Today we are going to talk a bit upon sepsis, how to identify it, and then after identifying, how to manage it. Now, next slide, please. What is sepsis? Sepsis is caused when the body's immune response becomes overactive in response to an infection. Per se, it is not an infection, it is the response to the infection which causes inflammation, and then it affects the working of the tissue and the organs. Now, how do you define sepsis? Sepsis is not a single entity, it is a syndrome in which there are multiple body dysfunctions which progress altogether in a predictable way and can cause various clinical presentations along with high mortality rate if left untreated. Okay. So this is a graph which shows how bad the sepsis be. This shows that the mortality of sepsis is just second to the ruptured aortic aneurysm. It is more than what the mortality of the MI and that of the stroke. Now, as I've already told you that sepsis is a syndrome. So its spectrum also varies. Sometimes it can be just an inflammatory response, or it can be a full-blown sepsis, or severe sepsis, or septic shock. Now, coming to the definitions of these, it's very important that you identify what you are dealing with, whether it's SIRS, severe sepsis, or shock. Now, SIRS is defined when your patient has a heart rate of more than 90, respiratory rate of more than 20, fever of more than 100.4, or less than 96.8 body temperature, with abnormal WBC count, which means between 4 to 11,000, and low PCO2 levels. Sepsis is defined when any of the two SIRS criteria are there, plus you have evidence of infection anywhere in the body. Severe sepsis is defined when you have sepsis, along with that you have hypotension, or you have end organ damage and elevated lactate levels. All right. Shock is defined when you have severe sepsis. Along with that, you have persistent organ dysfunction. Now, as we go high up in the spectrum of sepsis, that is from SIRS to sepsis to severe sepsis to shock, the mortality rate increases. So this is just a pictorial presentation of how the mortality increases. As you can see, SIRS, I've already told you, if the body temperature is defined when the body temperature is more than 38 degrees centigrade or less than 36 degrees centigrade, heart rate of more than 90, respiratory rate of more than 20, that means patient is tachypneic, and PaCO2 levels of less than 32, with WBC count in the abnormal range or more than 10% of bank cells. Sepsis, which means SIRS plus infection, severe sepsis means sepsis plus end organ damage, and shock means severe sepsis with hypotension. Now, coming to infection, what is when infection happens in the body, what is the normal response of the body? It can be just a localized infection because body tries to contain it, or it could be just that body may react in a non-specific inflammatory response, or it can go in 3 phases, which is vasodilatation, which means that the blood flow to the site where the infection is, it increases, and there is infusion of antibodies which help to prevent the infection. The vascular permeability increases, so the antibodies and the cells exit and they enter the infected tissue. Now, once all these things are controlled, the body tries to control it and the infection is controlled, the tissue repairs itself. Now, coming to the pathophysiology. How does sepsis occur? Sepsis occur when there is uncontrolled exaggerated immune response, because sepsis means SIRS plus any of the evidence of infection in the body. SIRS is immune response, which can result, this immune response can result in endothelial damage and disruption of the coagulation system, leading to vascular dilatation and capillary permeability, so that the inflammatory response becomes systemic. Once this systemic inflammatory response is there, it results in end organ damage and in cell death. Now, this is the spectrum of sepsis. Sepsis can be because of the bacteria or fungus, parasite, virus, or other diseases. SIRS may be because of the infection or because of other non-infective causes like trauma, burns, pancreatitis. Now, coming to SIRS, how do you define SIRS, which is systemic inflammatory response syndrome? It comprises of the abnormal signs. It has many triggers, but most common is the infection. Many triggers I've already outlined, like trauma, burns, pancreatitis. Okay, so this SIRS usually does not rely on the blood test reports. It relies mostly on temperature, heart rate, respiratory rate, and the mental status. Now, coming to sepsis, what are the risk factors? Whom do we think that the patient, when we think that the patient is at risk? So those patients are who are of extremes of age. That means who are quite at the opposite spectrum, quite old or quite young. Many a times, since they both they are quite young or quite old, they are not able to communicate. So you need to have a careful clinical assessment to identify SIRS and sepsis. These are the patients like who have developmental delay or cerebral palsy, who cannot communicate. These are the patients who can have all these risk factors. Now, patients who have recently undergone surgery or have some invasive procedure done, pregnancy termination or miscarriage, any of these interventions are a risk factor for sepsis, because in all these procedures, something is being done to the body which is done externally. Or patients who have reduced immunity, like patients who are on steroids or immunosuppressive drugs or any immunosuppressive vasculitis, autoimmune disorders, any of these patients are at risk. Now, risk may also in clinical conditions like diabetes, which is a very high risk for sepsis because they already have low immunity, liver cirrhosis, autoimmune disorders, HIV, patients who are bed bound, because patients who are bed bound usually have many lines inserted or they require some interventions. Now, patients with sickle cell disease, any other hemoglobinopathies, patients with splenectomy, patients with compromised skin like burns, ulcers. So where the immunity is low. Now, patients who have already chemotherapy or post-organ transplant, which may be anything, liver, kidney, bone marrow, any transplant, because they are already on immunosuppressive. Chronic steroid use, recent antibiotic use, because the normal flora of the body is suppressed, it is altered. So any other, when the normal flora is altered, the other organisms may cause infection. Patients who have indwelling catheters like dialysis, Foley's, PICC lines, any PEG tubes, they are at risk. Now, coming to the signs and symptoms. Now, signs and symptoms, most common is fever. Now, here's the catch. Elderly patients, usually they may not mount a febrile response. They may just appear listless or in altered sensorium, or they may stop eating, stop communicating. So that is your first red alert that the patient may be landing into sepsis. Or it may vary, like flu-like symptoms, shaking or chills, nausea, vomiting, altered mental status. Many odd times, these patients do not appear acutely ill. Now, once sepsis is there, there may be multi-organ dysfunction. It may affect various other organs also, like CNS. They may present to you with altered mental status. They may have respiratory symptoms like tachypnea, hypoxia. They may have kidney involvement in the form of decreased urine output or frank renal failure. They may have liver involvement in the form of jaundice or coagulopathy.
Nitin? Driver.
They may have metabolic dysfunction in the form.
Oh.
Now there has been an united effort to improve survival from sepsis in the form of, there are few take-home points which everyone should know about. One is rapid identification, early identification of the sepsis, fluid resuscitation, and early antibiotic therapy. The healthcare physicians plus the medical, all the healthcare workers which are involved in the patient care, they should be educated how to identify sepsis. Care bundles should be monitored. Sepsis alert teams can be formed in the hospitals, charts to be reviewed, and administrative support at all levels. Because sepsis is a medical emergency. The patient survival rate decreases acutely if you delay the time to start the antibiotics. Ideally, antibiotics should be given within an hour of identification of the sepsis. As the time passes by, the mortality increases and the survival decreases. Now, identifying. How to identify sepsis? First, you need to look for the signs and symptoms in the patient and ask about infection. Patient may not be able to pinpoint you about the signs and symptoms or the discomfort he's suffering from. He may be in altered sensorium or may not think that the history what he's going to give you is relevant. So you have to ask leading questions. You have to ask him about the risk factors. After that, detailed history, check the temperatures. If patient is having fever or if he is hypothermic, which is more dangerous. Look for the SIRS criteria. Look for shock, dehydration, and if possible, ETCO2. Now, treating a patient with sepsis. First, foremost is always the airway and breathing. If the patient is having low oxygen levels, start oxygen therapy, maybe nasal mask, NRBM, CPAP, invasive airway, so that your oxygen levels are more than 92 to 93%. Second is circulation. Whenever the patient is in shock, you have to get 2 large bore IV cannulas. Give NS bolus at 20 cc per kg. May repeat it if the lungs remain clear. Now, whenever you have in your mind that the patient may be suffering from sepsis, you need to communicate. It doesn't matter if the accepting facility has a formal sepsis alert response process. Whatever you can do, start the antibiotics, give IV fluids, fluid resuscitation, and antibiotics are very important. Now, respiratory component of sepsis. Respiratory component is basically because of the mismatch of the oxygen availability, because of the changing need of the organs. Because in sepsis, there is increased oxygen demand. That is why the patient may have respiratory symptoms. So you have to keep a saturation of more than 92%. Respiratory failure, because in these patients, they can decompensate quickly. So respiratory failure can happen. ARDS is a common complication. Now, once you have identified sepsis, how to treat it? For that, we have an early goal-directed therapy. Now, this early goal-directed therapy has shown to decrease mortality at 28 days and 68 days of the hospitalizations. Mechanism is still unknown, but it causes reversal of the tissue hypoxia, decrease in the inflammation and the coagulation defect. Now, this early goal-directed therapy has, which is also called a reverse trial, it suggests that the crystalloids should be administered to maintain a CVP at 8 to 12 millimeter of mercury. Many a times CVP is not there, or the patient has just landed and you're not able to, your hospital is not equipped to insert a central line. Give fluids. Start the crystalloids. Vasopressors should be added if mean arterial pressure is less than 65 millimeter of mercury. For that, you need an arterial line. If your central venous oxygen saturation is less than 70%, PRC transfusion can be done so as to maintain an hematocrit of more than 30%. Now, if your CVP, MAP, and hematocrit has been optimized, but yes, the oxygen venous, central venous oxygen saturation remains less than 70%, you can add dobutamine. Now, coming to the Surviving Sepsis campaign, these are the international guidelines, which tells us that initial resuscitation, which has to be done within 6 hours, has to be done in patients who have hypotension or elevated lactate levels. Resuscitation has to be done using crystalloids, or you may use colloids also. The goals should be clear. CVP target should be 8 to 12 millimeter of mercury, mean arterial pressure of more than 65, urine output of 0.5 ml per kg per hour, and central venous oxygen saturation of more than 70%, or mixed venous saturation of more than 65%. Vasopressors can be added to maintain a MAP of 65 millimeter of mercury or more. Norepinephrine, dopamine, which should be centrally administered, are the initial vasopressors of choice. You can add noradrenaline also as first alternative agent. There's no role of dopamine for renal protection. Vasopressin can also be added in the dose of 0.03 to 0.04 units per minute to increase the blood pressure. It causes and it permits a dramatic decrease in the vasotherapy, in the vasopressor therapy, but it has some side effects. Cannot be given in patients who have cardiac arrest, who have skin necrosis, who have decreased cardiac output, or who have intestinal ischemia. Now, coming to the ventilation, if your patient requires ventilation, there are some things which you need to keep in mind. First is the lung protective ventilation. Tidal volume of less than 6 ml per kg or as low as 4 ml per kg, depending upon your plateau pressures. Plateau pressures under no circumstances should exceed 30 centimeter of water, because this lung protective ventilation has shown to decrease the mortality and is beneficial in septic acute lung injury. Advantages, as I already told you about, it decreases the mortality rate, causes lower levels of cytokine release, and less organ dysfunction. PEEP has not shown to have any significant difference in the mortality. Now, for the diagnosis, you need to send cultures before starting the antibiotics, but if that shouldn't delay you from administering antibiotics. If the cultures are being delayed, administer the antibiotics. You don't need to wait for the cultures. The more cultures you obtain, more are the chances that you'll be able to grow some bug. Obtain 2 or more blood cultures, because one or more blood culture should be percutaneous. It should, and one blood culture should be obtained from any device which has been there for more than 48 hours. Antibiotics, IV antibiotics should be administered as early as possible and always within the first hour of recognizing the sepsis. Reassess antimicrobial regime daily to optimize its efficacy, prevent resistance, avoid toxicity, and minimize the cost. Now, these are the antibiotics depending upon your patient is immunocompromised or immunocompetent. Usually in immunocompetent patients, you can start with ceftriaxone or ticarcillin, clavulanic acid, or piperacillin, tazobactam. Other antibiotics you may consider are imipenem, cilastin, meropenem, gentamicin. Now, if patient is neutropenic, then carbapenems and cefepime are mostly used. They are recommended. Plus, you can use ticarcillin, clavulanic acid, or piperacillin, tazobactam, plus tobramycin. Patients who have splenectomy, they are already immunocompromised, so gram-negative along with that positive cover is recommended, along with ciprofloxacin and levofloxacin. In patients who have acquired immunodeficiency syndrome, you can start them with cefepime, piperacillin, tazobactam, plus tobramycin, and with atypical cover. Activated protein C. Now, therapy with activated protein C has been reported to decrease mortality initially, but in the PROVESS trial, it was shown not to have any advantage, so it has been deferred now. It's not used. Steroids definitely should be used. If your patient is in shock, you can consider IV hydrocortisone in patients with septic shock. When hypotension responds poorly to adequate fluid resuscitation and vasopressors, hydrocortisone is preferred over dexamethasone, and the therapy dose should be around 300 milligram per day. There is no role of corticosteroids in sepsis if your patient is not in shock. Now, coming to the adverse effects. The patients who are in sepsis may have neuromyopathy, they may develop hyperglycemia because of the usage of steroids, they may have decreased number of lymphocytes, may result in immunosuppression. They may have loss of intestinal epithelial cells because you have not been able to feed them for a couple of days. So, any questions? Simran, I guess no questions. So we'll just close the session.
Yes, ma'am. Thank you so much, ma'am.